Okay, good. So the Manish and Dr. Kaul and
Yes, Samin.
rest of our panelists, we welcome you from Godrej Hospital with Dr. Chetan on my left side and rest of the staff. So we had two cases. One is little simple kind of a warm up, and the second one will be the left main.
Great.
So I'll ask Dr. Chetan to present the history of the case.
This is a young lady, 49-year-old lady, who presented with history of rest angina, and ECG showed a non-cave anterior wall myocardial infarction. And an angio was done about 3 days ago. And can we have the angio shoots to show them?
Okay, we see
Good.
the angio.
Yeah.
No, that's okay. You keep it here. No, it's playing. Yeah. No, this one, us. Yeah, good. Okay. So as we said that this afternoon session is a bifurcation. So this is kind of a 0-1-0 because the lesion is only in the distal segment of the bifurcation and seems to be both the diagonals and proximal segment of the LED are preserved. But very angulated vessel, big mismatch in the proximal vessel to the distal.
Yeah, we see that nicely.
Yeah, and diffuse
So while we are
disease
discussing,
LED.
we are ready to, yes. So we have selected the cyan blue Asai wire. And the question, there will be some discussion after we do an initial dilatation, that do we need to protect the diagonal? I think that will be one of the issue. Besides, otherwise, once we cross it, PTCA and then subsequent long stent to cover both the lesions.
Yeah, so this is a very good discussion for provisional bifurcation, Dr. Sharma. It's a nice case.
Yeah.
So what is a 6 French radial system?
It's a 6 French radial, and actually patient had a radial procedure a few days ago.
Okay.
They were still able to go through it. Slightly painful, but which happens.
A long segment of disease.
Good. Now the wire has gone. We are given a heparin, 7,000 heparin. You ready with the balloon?
Now, Dr. Sharma, for
So we
the
are
audience,
selecting a
when do you-
2.515 mosaic.
Okay, when do you protect the side branch in this case? Even though you're not going to stent it, your approach is provisional. When do you decide you're going to wire it or not wire it?
That's a very good point. I can tell you I have very low threshold of protecting the side branch with a wire. And remember, there is a latest paper last year, one registry had almost 18-20% side branch occlusion, even in the cases where there was no disease. And that there was no side branch wire was used for protection. So I actually have a very low threshold. So my recommendation here will be that after we do an initial dilatation, so that we just put a wire into the side branch and then stent across.
So your approach is after pre-dilating to put a wire in, not pre. Okay.
Well, I mean, just basically, or we can do it anytime, but only question is that once you have wire movement and all, some get crisscross and so,
That's a great,
Okay,
yeah.
yeah.
and particularly there is no disease here. Yeah, that's correct. But if there is a mild disease or mild to moderate, then I would start with the wire to begin with.
Front, yeah.
Go.
You can tell them the balloon.
Yeah. No, okay, slow. Many times it is angulated, you have to go slow, otherwise it will push back. 1 second.
Go
Yeah.
very slow on dilatation.
Go to, it's a 2.515, 2.515 mosaic NC balloon. 4, 6. Maybe 2.5 is little too big for the vessel.
Again slip back.
Negative. Yeah. But we go a little further. Just go a little further now. Good. Now you go. it's pushing it out again.
5, 6, 7, 8, 9, 10.
Very fibrotic lesion.
Yeah, here it
Yes,
is.
very fibroid. And although it looks acute syndrome, patient has a troponin positive.
Yeah, yeah.
Okay.
Yes,
Let's go
positive.
distal.
You want to size?
A little further. No, just dilate here. Yeah, dilate here. Good. Okay.
Down. Take a picture.
Yep. We'll take a picture now. Come back in the guide. No, bring the balloon in the guide. Yeah, good. Cine. Go to a little more RO. Slightly. Good. Yeah, I think there is a little distal dissection which
Yeah,
is okay.
distal dissection.
As long as your wire is good. So, yeah. Fine.
So it's a large cascade.
Now
of diagonals.
lengthwise, we have decided the 44 millimeter. Yep. Let's get a wire. We need one extra new wire, additional wire into the diagonal. Give us this. Give us this and play the last view so we can see it a little better. No, give the wire. Yeah, good. So good. So we have the second cyan blue because cyan blue is the workhorse here. Good.
That's a very good wire, the cyan blue.
Yeah. Actually, I know that a lot of people really love it. We did try quite a bit at Sinai, but part of that is still since got so good at run through, which is the workhorse wire for us there. But this, a lot of people love cyan blue. Manish, what is your workhorse wire at Columbia?
So it used to be BMW Universal, but recently I've switched to the new Samurai wire,
Which one is that?
which is a Boston Scientific wire, which is
Okay.
a fantastic
Leave it.
steel
Leave it here.
workhorse wire. It's an advantage over the Pro Water.
Leave it there.
But
Yep.
all these are very good wires. It
Let's get
depends
this
on what
stand.
you're using.
That's right. I think the nearly equivalent.
2.5, right?
What you're used to should be the choice.
2.75 or 2.5?
2.5. We are 2.5. Here, let's play the last one. We decide with the vessel size and the length. I think we go with the 2.5.
Yeah.
So you have a long lesion, huh, Samin?
lesion.
Yeah, he's
Yep.
short.
So
He's
2.5, 44.
44.
Yep. 2.5, 44 millimeter. Yeah, show other way. This is called Biomime Aura.
Aura.
2.5, 44.
Okay.
Okay.
And the strut thickness is 65? 65 micron. Just like Synergy.
Yeah. That's right.
And you sure?
Dr. Kaul, what is your
that
wire?
the desktop, distal
Workhorse wire.
section is protected with this
Hello?
length, yes?
Yeah, I usually use BMW Universal. That's our workhorse.
I'm sorry?
They should ensure that the distal
Great wire.
section will be covered by this stent
Yes,
because
yes,
the,
yes,
the
yes, yes,
distal
yes.
section is,
It's using a 44.
Evaluating,
millimeter.
yes.
Yeah.
yes.
Yes.
But I agree, the BMW is a good wire.
That's
In
right.
Brazil, we use a lot.
Yeah.
Even though in our acute case of
Actually, a little
EMI,
too long, but
we
that's
have a
okay.
good experience.
So that's okay. Yeah, I think the 40 would have been fine, but we had the 44 here, and we'll take a little picture. Good?
Yeah.
It covers nicely. Good. Go up.
Yeah.
Yes.
Yeah.
Seems good.
9, 10, 11, 12.
Good. Okay, let's say, yeah. अब थोड़ा दर्द होगा अभी?
और दुकेश?
Negative. Yeah, I think we can just post dilate with the 2.5 balloon we have. Go once again. We usually go 2 times. The idea is the second time you have a little better expansion of the stent against the resistance of the lesion.
Yeah, I agree. Yeah, I
10,
always
12.
go twice as well,
12, good.
Okay.
especially with these delivery
Negative.
balloons that are very semi-compliant and compliant.
Right. And now question will remain, and that is what debatable, that do you post dilate or you take the wire out, your side branch, recross it, and then post dilate. So I think we'll ask everybody's opinion. Let's bring this one in the guide. Good. Yeah, we take this one out with no use.
How many atmospheres do you use in deployment of stents this time?
This one was 12 atmosphere.
12 atmospheres.
Yeah, my approach to that question is if I take a picture and there's good flow,
Yeah,
then I will
take it out.
pull the wire out
Yes.
and rewire it and finish with my non-compliant balloons and not necessarily do kissing,
correct.
but just have it ready if I need to. But here, the pot will be
Right.
important
That's right.
because there's a
Good.
very large proximal segment compared to the distal
And then
segment.
the site of the lesion needs,
We'll
more
take out the
work.
wire and
Fluoro.
rewire.
Yeah,
Yes. I
Go on
completely
forward now.
agree with Professor Manish. This is an approach in Brazil. Professor Eduardo Souza taught me this even my earliest days.
What is happening? She's feeling pain?
ઓછું છે ને હવે? Give her some sedation.
And let's give some nitro. Yeah. So likely what we'll do the same, we'll just change the wires.
swap
And
wires.
take the main vessel wire and cross the side branch. Why she's getting so? You will die.
Some pain, maybe diagonal.
No, diagonal was good.
Almost there. No.
It's okay.
Higher up.
Yes.
Yes.
Great.
Good. Okay. Let's bring our 2.5 balloon.
ONC balloon दिया?
Now somehow patient, whether it's acute stretch, because we have very good flow. Show the last picture. There is no edge dissection, everything looks very good, but patient had a lot of chest pain. Go. Yeah, the proximal, I think we may need a 3O balloon,
Yes.
Yeah, you'll need to
or
proximally
even
optimize.
3.25. Good, advance side branch wire, 1 second, 1 second.
Sorry.
No, no, 1 second, 1 second. See that wire happen? That once you have a soft portion of the wire, always, you have to be careful because that your wire balloon may distort that wire. Good,
Okay.
good. Okay, go up. 6, 8, 10, 12, 14, 16,
18.
18. Good. Negative. Okay, go up here. 12, 14. Negative. Okay, go up here. 20,
3 over
20.
315. Yeah. NC.
Negative, negative. Okay, so now we take the picture and then we decide what else need to be done. Sorry. Everything looking very good. We just had to pre-dilate now. The Manish, in lieu of the time, if you want to go to your lecture, will give us about 45 minutes here to get the left main case ready.
Very good.
Okay.
Or
Very
any
good.
question
Very
you have
nice-
to us.
Very nice demonstration of a provisional case.
Excellent.
Okay. Thank you. Thank you.
Okay, so let's introduce, having seen a bifurcation, really an expert in all complex PCI, Dr. Mohammed Munawar will be presenting on bifurcation tips and tricks. Dr. Munawar, thank you.
Thank you.